So today's topic is a very important topic, uh, topic on insulin. Okay. So you all know that diabetes is a very common disease in the society. And in spite of many OHs, what we have discussed last class, metformin or your sulfonylureas, alpha glucosidase inhibitors, or your thiazolidinediones like pioglitazone, and then your DP4 inhibitors, different gliptins are there, and also SGLT2 inhibitors and different combinations. In spite of the so many drugs, OHs in our armamentarium, still the control of the blood sugar is very poor in our society. So there is always a role for the insulin therapy to control the blood sugars very effectively to reach your euglycemia so that you can prevent the long-term complications of the diabetes, either the microvascular or the macrovascular complications. So ultimately, the euglycemia, long-term euglycemia is very ideal to avoid the long-term complications. So to reach the long-term euglycemia, it is very difficult to stay with the OHS alone, and there is always a role for the insulin to be added for most of our population. Nearly 30 to 40% of our type 2 diabetics, they need insulin. Imagine the number of the type 2 diabetes in India, nearly 10.5 crores. So 30 to 40% means a lot of the people in India, they need insulin, but unfortunately, insulin is the most underutilized drug in our Indian diabetics population. So with this background, we will move on to the topic proper. You all know that the insulin is a very important hormone. Yeah. This is one of the best drugs ever invented in our medical sciences, insulin. See, you all know that insulin is invented by or co-discovered by Frederick Banting and the Charles Best. So this Banting was an orthopedic surgeon and the Best was a medical student. So both these people, they invented the one of the beautiest molecules in our medicine, insulin, way back in 1921, and they got the Nobel Prize next year. See, this fellow is the Thompson, 14-year-old. He became the first patient to receive the Banting and Best pancreatic extract at Toronto Hospital. Though Thompson's condition was much improved, he had an allergic reaction to the impurities. So this extract was a lot of the impurities in the solution. So a lot of the people, the earlier days when were introduced to the insulin therapy, so even though the blood sugar have come down to the normal, they used to develop a lot of the allergic reactions, either the hypoatrophy or hypertrophy, etc. So for that, the professor of the physiology, where the Banting was deputed as an orthopedic surgeon, he was deputed to the Department of the Physiology under the MacLeod. And so that is the reason MacLeod and the Bantings were awarded the Nobel Prize at that time, because Nobel Prize was should not be given to a medical student. So Banting and the MacLeod, they got the Nobel Prize, and Banting shared his prize with the West. As a medical student, he helped a lot to the this discovery of the insulin. In the same way, MacLeod, he shared his prize with the Colip, who is a physics professor and who helped the impure insulin to be converted to a purified insulin to avoid the allergic reactions. So if you see the physiology of the pancreas, you know that the pancreas is having the two functions, exocrine function and the endocrine function. And in fact, endocrine pancreas is just 1% of the total pancreas. That means 99% of the pancreas is exocrine. A lot of the acini will be there and they secrete your pancreatic juices. And 1% is your endocrine pancreas. You have the alpha cells, beta cells, delta cells, etc. And alpha and the beta cells are very important. So in the beginning, we thought that only the beta cells were important because they secrete the insulin, and because of the lack of the insulin, you have the hyperglycemia. Of late, alpha cells also are also very important for the simple reason that they secrete glucagon, and hyperglucagonemia means hyperglycemia. So in all the diabetic individuals, not only there is the deficiency of the insulin, there is also exaggerated glucagon. So these two are important to cause hyperglycemia in our individuals. And insulin molecule, it is a peptide. So first one is the pre-proinsulin, and that can be converted to the proinsulin, and finally to the insulin. And insulin is having the two chains, A chain and the B chain. A chain with the 21 amino acids and B chain with the 30 amino acids. These two chains are connected together with the C peptide, that is the connecting peptide. So it is very easy to calculate the C peptide, and it is very, very difficult to calculate the insulin levels. So if you calculate the C peptide levels, for one C peptide, there is one insulin, endogenous insulin. So the more the C peptide levels in your patient, that means he is secreting more and more insulin. So that is hyperinsulinemia. Suppose if a patient is having the low C peptide levels, that means his endogenous insulin production is very, very low. So that is how you differentiate between the type 1 diabetes and the type 2 diabetes. So in type 1 diabetes, the C peptide levels are very, very low. That means endogenous insulin production is 0. Whereas in type 2 diabetes, the C peptide levels will be very good. That means the insulin production is the good, even though the insulin is not actively functioning. So because of the insulin resistance. So this already told you the A chain and the B chain, because these amino acids are very, very important of late. Because earlier we used to have only the regular insulin or your actropids or your mixed-tard insulins or your insulin N or Osilin, etc. or insulitard. Nowadays we are using more of the analog insulins. So analogs, because of this change in your amino acid sequences in the beta chain. So in the beta you have the 30 amino acids, 28 and 29 are the proline and the lysine. So that is the reversal, that is the Lispro, that is the one analog insulin. It's the fastest acting or the rapid acting analog. In the same way, other analogs also, they formed because of the alteration of these amino acids. So that is the reason these amino acids are also very, very important. Insulin is useful not only to the carbohydrate metabolism, but also to the protein metabolism and also the fat metabolism. That's what we discussed when we were in the first module itself. See, this insulin here, it acts mostly on the 3 areas. One is the liver, the second one is the muscle, and the third one is the adipose tissue or the fat cells. So in the liver, the glucose is stored in the form of the glycogen. So when a fellow is on fasting, this glycogen which is stored in the liver is converted to the glucose, that is called glycogenolysis. So when the excess glucose is there in our body, that will be goes into the liver as a storage form, that is the glycogen, and that will be useful in the presence of the insulin. So not only that, in the insulin in the liver, it improves the lipogenesis, not the lipolysis. In the same way, that also reduces the neoglucogenesis. So neoglucogenesis means glucose production other than from the glucose structures. That means from the amino acids and the fats, converting to the glucose is called a neoglucogenesis. That can be halted by your insulin. So insulin is having very good effects on the liver, promoting the glycogen, that means storage of the glucose, and not making the amino acids and the fats to break down into the glucose, that is neoglucogenesis. And also there will be the lipogenesis in the liver. So if you see the muscle, that is also very important, because the excess glucose is stored in the muscle again as the glycogen. So in fact 60% of the glucose is stored in the muscle, and 20 to 30% is stored in the liver. So in the same way, the insulin helps you in promoting the glucose entry into the muscles. That is called insulin sensitivity. Okay. So not only in the muscle, not only the glucose, the insulin also helps in amino acid deposition and protein synthesis. So that is the reason in type 1 diabetics, if you introduce the insulin, they gain body weight. So they will be chubby. That is because of the protein synthesis. So the insulin helps in protein synthesis also. I told you the actions of the insulin as far as the liver is concerned. And also I told you the actions of the insulin in the muscle. So to help the storage, more and more storage of the glucose in the muscle as the glycogen, and also the more protein synthesis. And then into the adipose tissue, that is the fat cells. Insulin also helps here. It promotes the lipogenesis. So that is the reason in the insulin deficiency population, you will have the lipolysis. So the more the lipolysis, more the free fatty acid production, and more the free fatty acid production, more the ketone bodies. So that is our histone and histoacetic acid and beta hydroxybutyric productions. So the lipogenesis will be there in the presence of the insulin in the adipose tissue. In the same way, the glucose uptake will be there, that is the glucose sensitivity, and it inhibits the lipolysis. So these are the functions of the insulin on the liver, in the muscle, and also in the adipose tissue. So this is the very, very important hormone in the body to promote glucose entry into these tissues. And then glucose and insulin metabolism in the normal conditions. So euglycemia. See euglycemia, see all the non-diabetics, there will be the euglycemia. So this euglycemia is tightly maintained in the humans by the simplistic bihormonal model that is called glucose appearance and glucose disappearance. So how the glucose appearance into the circulation? Because our food intake. Okay, from the intestinal absorption, glucose appeared in the circulation. And also the glucagon. I told you the alpha cell secrete in the glucagon. This glucagon helps in glycogenolysis and neoglucogenesis. So that also helps you in the glucose appearance. So the glucose appearance in the circulation because of the two things. One is your glucose appearance in the circulation because of the two things. One is intestinal absorption. The second one is glucagon hormonal. So intestinal absorption because our food intake, maybe your rice or sweets or etc. And the glucagon because of this glycogenolysis and neoglucogenesis. And glucose also disappears from the blood because of your powerful hormone, that is the insulin. So this is what happens in the normal individuals. When their blood sugars are maintained the normal, that is because of the balance between these three things. One is your food intake, intestinal absorption. The second one is your very good glucagon. And the third one is very, very good insulin. Okay. So if the balancing of these three hormones are there, and you will not have hyperglycemia, because glucagon causes more and more sugars, and insulin reduces those blood sugars. And if you are good in your food intake and intestinal absorption is less with the sugars, and obviously your euglycemia is maintained as long as you maintain these three structures in time. So what happens when any one of these organs are damaged or any one of these things are at fault, and definitely the people will get hyperglycemia, and a chronic hyperglycemia you term it as diabetes. So during the fed state, glucose appearance is primarily influenced by the gastric emptying time. So the more the gastric emptying time, the less the absorption of the sugars from the intestines, and there won't be any hyperglycemia. So the same thing happens when you take the quinoa, or you take the brown rice, or you take the millets. So they take a longer time to from the gastric tract. So that is the reason their blood sugars will maintain at a normal levels. So what happens when you take high amount of the sugars or the bread or the white or the rice, etc. So definitely the gastric emptying time is very less there. So you will have a postprandial hyperglycemia. And during the fasting, endogenous glucose production is mediated mainly by the hepatic glycogenolysis during the first 8 to 12 hours, and followed by the neoglucogenesis. The kidney also plays a role in this glucose production, so in the endogenous glucose production. So now move on to the basal insulins and the bolus insulins. See, this is the basal insulin. So we need insulin for these functions. Already I told you the what are the functions of the insulin. So insulin functions on the liver, on the muscle, and also on the adipose tissue. We need some amount of the insulin. That is the basal insulin. How much they say? How much we secrete? About 0.5 to 1 unit per hour is our basal insulin secretion. So that will take care of our basal glycemia. And this is the postprandials, okay, or the bolus. So these are the prandial insulins. So after the food challenges, typically after the breakfast, we take the three foods mostly here: breakfast, lunch, and the dinner. So lunch and the dinner, insulin secretion is increased 3 to 10 times over about 4-hour postprandial period, then returns to the basal rate. So immediately after the food, the insulin secretion will be increased very much, because to control the postprandial hyperglycemia. So patients with the type 1 diabetes typically lack the clinically meaningful insulin secretion, and those with the type 2 diabetes show a blunted glucose mediated insulin secretion plus approximately pulse of approximately 70% of the normal. See, the insulin is secreted in the two phases, first phase and the second phase. So first phase, whatever the insulin is stored in your beta cells, that will be released immediately after our food intake. That is called first phase of the insulin secretion. That starts within the 3 to 5 minutes of our food intake and lasts for about the 10 minutes. So that is the first phase. This first phase insulin was released in a high manner, so that will tackle your postprandial hyperglycemia. And after the food intake, so this glucose is a good stimulus to our pancreas to release more and more insulin. Again, some amount of the insulin also will be secreted after the few minutes or few hours. So that will take care of the latter part of the postprandial hyperglycemia. As in type 1 diabetes, as there is no insulin at all, so obviously their postprandial blood sugars will be very, very high, provided if you don't give the insulin from the external source. In the same way, in the type 2 diabetes also, the first phase of the insulin will be lost in type 2 diabetes. So what will happen to their postprandial blood sugars in type 2 diabetes? That will be increased because of the absence of the first phase of the insulin secretions. And the second phase of the insulin secretion is also blunted, so that not enough insulin is released to tackle the postprandial hyperglycemia. So that is the reason in the type 2 diabetes also, you will have a postprandial hyperglycemia and also the random hyperglycemia. See, if you take the lunch at the 1 p.m., postprandial blood sugar means maybe 3 after maybe first hour, at the second hour, hardly 2.5 or 3 hours. Even after the 4 hours and the 5 hours also, these people will have the hyperglycemia that called as a random hyperglycemia. Even at the 5 o'clock, if you check the blood sugar, it will be 250 or 230. So that means that fellow is also having the random hyperglycemia. So that is all because of the blunting of the second half of the insulin secretion and also loss of the first part of the insulin secretion. So the first phase insulin secretion is lost, not only in the patients with the type 2 diabetes at the diagnosis, but this is very important, but also in patients with the pre-diabetics. Okay, so that is the reason we should check the pre-diabetics, also identify the pre-diabetics in our society, so that unless you give a good dietary approach, or unless you advise them for a physical activity, so this insulin secretion is blunting, and finally these people will be converted to the diabetics very fast. So the conversion rate of the pre-diabetes to the diabetes is very, very high in our Indian population, and it is our duty to identify the pre-diabetics in the society. Pre-diabetes means fasting blood sugar 101 to 125, and postprandial blood sugar 144 to 141 to 199. So anyone's blood sugar, fasting blood sugar between 101 to 125 is a pre-diabetic, and anyone's postprandial blood sugar is between 141 to 199 is a pre-diabetic. Once it is 126 or 200, so definitely they are the diabetics individuals. So if you don't give the importance to the blood sugars of fasting 110 and the postprandial 150, what will happen? These people will later turn converted into the diabetics very fast. So that is the reason Indian population, the conversion is very high, whereas the Western population, the conversion is not that high because of the effective dietary approaches and the effective physical activity in them. So all our people, they need a good dietary approach and the exercise approach, and also some meditation or yoga, etc. Not only in reducing the hyperglycemia, but also making them not to enter into the diabetes once they are the pre-diabetics. So when recommendations for the initiation of the insulin therapy, when we initiate the insulin in our population, see, start insulin even at the diagnosis. At the diagnosis itself, some people, they need insulin. For example, type 1 diabetics. So at diagnosis, they need insulin. After 5 years, they need insulin. After 10 years, they need insulin. On the day of the death also, they need insulin. So the insulin is needed for their survival. So that is okay. What are our other investigations? What are other indications to start the insulin in type 2 diabetes? See, at the fasting blood sugar more than 250, postprandial more than the 300, or HbA1c more than the 9%. Even if the fellow is diagnosed as the type 2 diabetes, even at the time of the diagnosis itself, you may need an insulin therapy for them, because to reduce the glucose toxicity in them. But usually we don't give the insulin at these levels. So the fasting 250, definitely there is an indication to start the insulin. But postprandial 300, so we can control with sulfonylureas or with the metformin or with alpha glucosidase inhibitors, etc. And even HbA1c 9 also we don't start with the insulin therapy. Maybe you can wait up to the 10 or 10.5 or the 11 also in our Indian population. But one thing is very clear. If the patient is symptomatic with nausea, some vomitings, or loss of body weight, or polyuria, polyphasia, polydipsia, if the patient is in a catabolic condition, so definitely there is an indication to start the insulin therapy irrespective of these values. Okay, if you see one patient, say some Subbarao, he is having hyperglycemia for the last 10 days. So having the weight loss of about 3 kgs or 4 kgs, and nocturia, polyuria, okay, and then the polydipsia is taking at least half liter to 1 liter once in an hour or once in the 2 hours. So that indicates that this fellow is having a most catabolic features. So the only answer for them, only treatment for them is always initiation of the insulin. So all symptomatic diabetics, so definitely there is always a role for the insulin therapy. Here the insulin is not for the lifelong insulin. So to make him euglycemic and you make him asymptomatic, and then you can change over to the OHS, because this patient is a type 2 diabetes, not a type 1 diabetes. So type 2 diabetes, even at the time of the diagnosis itself, provided if the patient is symptomatic and presenting with a high blood sugars. Suppose the patient has a systemic infection like pulmonary tuberculosis. On the day 1, he presents with a cough, some breathlessness or sputum production, and then you take an X-ray, and X-ray shows the upper lobe cavities, and sputum AFP was the positive. So obviously it's a pakka case of pulmonary tuberculosis. So how to treat? And then you also advised to get the blood sugar done. So the blood sugar is 250. So you asked the leading question, what is the duration of the diabetes in him? He said no. This is the first time the blood sugars are higher values. So that means he was diagnosed both pulmonary tuberculosis as well as the diabetes in your this visit. So that means diabetes plus pulmonary tuberculosis. So definitely you need an insulin therapy. How long? At least for the first intensive phase. So the 2 months intensive phase, you give INH, rifampicin, ethambutol, pyrazinamide. So definitely you see that with the insulin therapy, this patient should be converted into the negative. AFB positive earlier, there's an open case. So AFB should be negative. So once you start the insulin therapy, once you start the ATT in an optimum dosages, that means the INH may be 5 milligrams per kg body weight, rifampicin 10 milligrams per kg body weight, ethambutol 15 milligrams per kg body weight, pyrazinamide maybe 20 to 25 milligrams per kg body weight. So if you advise these all the 4 drugs for the first 2 months plus insulin to control the blood sugars very effectively, and these people will become sputum negative within a period of maybe 1 to 2 months. So once the insulin intensive phase is over, once his sputum positivity is negative, and definitely you can change over to the OHS. Otherwise, in the next 4 months also, you can continue the insulin. But here insulin is not the lifelong insulin for them. Okay. So in the same way, if the patient is presenting with say viral hepatitis, okay, viral hepatitis, and now the blood sugar is also 300. So bilirubin is 10, blood sugar is 300. So that means you presented with viral hepatitis, maybe hepatitis A or B or the C, etc. And you diagnose and you investigate him, it is hepatitis A only, B and C negative. Okay. So maybe he may need an insulin for the initial 10 days or the 15 days, and once the bilirubin has come down to the normal, and then you can change over to the OHS at a later time. So these are all the systemic infections. So maybe the carbuncles or the foreigner's gangrene or severe cellulitis. So in the or severe ascending urinary tract infections or lower respiratory tract infections or pneumonias or sepsis or pyelonephritis or cholecystitis. So these are all the indications, there are systemic indications where you are supposed to use the insulin along with those antibiotics to control both the diabetes as well as the infections very effectively. You all know that diabetes, so in diabetes and infection means both should be controlled aggressively at a time. So if you don't control the blood sugars, what will happen? If you control the infections with higher antibiotics, infection may come down, but because of the hyperglycemia, again the infections will go up. In the same thing happens to the blood sugars also. If you don't control the infections very effectively, so then again the blood sugars also will go up. So both the infections and the diabetes has to be maintained simultaneously with the insulin therapy and also proper antibiotics according to your culture and sensitivity. Yes, sepsis is a very common in our population. So where you have to use the insulin even at the time of the diagnosis. Acute myocardial infarction, the people admitted in the ICUs. So whether in acute myocardial infarction or cerebrovascular diseases or peripheral vascular diseases, anything, whether surgical ICU or the medical ICU. So definitely the only answer there is the insulin. So sometimes in the ICU, the one drug which is common to those 10-bedded ICU or 15-bedded ICU is sometimes insulin. So all the people, all the 10 people are the diabetics admitted in the ICUs. So the insulin is the only drug which is common for all the population. So acute myocardial infarction, definitely there is a role for the insulin. You should not use the metformin. You should not use the pioglitazone. You should not use SGLT inhibitors, etc. and etc. Unstable angina, it's up to you. Okay. So if the patient's sugars are well controlled, so definitely you can use the OHS. But at the time of the diagnosis, the patient is also having unstable angina. So always there is a role for your insulin therapy. Diabetic ketoacidosis, that is an acute metabolic complication. Okay. So sometimes, even the type 2 diabetes, they may present with the diabetic ketoacidosis. Last time I told you one example also. So the same fellow, diabetic ketoacidosis, definitely there is an answer for insulin only. Here in diabetic ketoacidosis, you should not use the mixed starts or the long-acting insulins or the basal insulins. The only insulin you have to use in the diabetic ketoacidosis is a regular insulin, whether your Actrapid or your Lispro or the Aspart. Pregnancy, yes. If it is pre-gestational diabetes, so definitely there is a big role for the insulin. If it is a gestational diabetes, you can use the metformin also. But at the time of the diagnosis, so definitely when the sugars are very high, so there is always a role for the insulin therapy. Perioperative care. So definitely in the perioperative care and intraoperative care or post-operative care, so insulin is the drug to be used to improve the healing, wound healing, and to avoid the long stay in the hospitals. So definitely the insulin will definitely helps the fellows in the perioperative care to reduce the sepsis levels also. After the OAD failure, that is a very common indication for the insulin in our population, type 2 diabetes. See, you might have seen a lot of the people with history of the diabetes 10 years, 15 years, 20 years. So whatever amount of the OHS you prescribe, so that they are not of much use, because always the fasting blood sugar is 250 or the post-prandial blood sugar is 400, in spite of your sulfurias or glimepiride 4 mg or the metformin 2000 mg or pioglitazone 30 mg or 45 mg or oglibose 0.2 mg 3 times a day, or your sitagliptin 100 mg or veldagliptin 100 mg, or even with the dapagliflozin 10 or empagliflozin 25. In spite of all these drugs, still the blood sugars are very high. And if you check the HbA1c, that is 9 or 10 or 11, in spite of 3 or 4 or 5 OHS. So that means this patient is on OAD failure, oral anti-diabetic drug failure. So again, the answer for this OAD failure is insulin. So that is the beautiful molecule. Insulin has to be used at the time of the diagnosis when the fellow is symptomatic, and in the ICUs, and in the sepsis, and in the severe infections, and also during the pregnancy and intraoperative care, and now with the OAD failure. So in spite of the many OHS, still the blood sugars are very high. So definitely there is a role for insulin initiation. So the good slide shows you all the insulins here. This is a short-acting insulin, your regular the soluble insulins, and intermediate acting insulin, NPH insulin. First you concentrate on this, don't bother about those hours. See, we have the short acting insulin, regular or the soluble, and we have the intermediate acting insulin like the NPH. Premixed human insulins, the regular and NPH, that is your mixed 30-70 or 50-50 or 25-75. Now the insulin analogs are available. They are the ultra rapid acting. So this is ultra rapid Lispro or the Fiasp. And then the rapid acting, you have the Lispro, Aspart, and the Glulicin. We often use the Lispro and the Aspart. Long acting, you have the Glargine, the Detimer, and the Deglutec. And we use both the Glargine and the Deglutec rather than the Detimer in our practice. Now the Glargine 100 units were available earlier. Now the 300 units is also available. Premixed insulin analogs. So that means a short acting with the proteminated. That means your say Lispro. So the Lispro mix is also there. Okay, so your Novo Rapid, Novo Mix will be here. Same like your mixed starts 30/70 like that. And then insulin co-formulations. So IDEG Aspart. So Aspart is our rapid acting analog, and IDEG is your that is your Deglutec. that is our basal insulin. So the basal insulin plus rapid acting analog. So that can be given in some cases where the fasting blood sugar is very high and also the post-prandial blood sugar is also very high. So if you give this combination, the aspart will take care of the prandial part, whereas the degludec will take care of the basal part. So these are the different insulins available in our hand right now. So short-acting, regular, soluble. So some examples: your atropine, or osilin, or insulin, okay, or insugen. They are all that. Intermediate acting NPH, your insulatard, osilin N, insulin N, insugen N. So they are the NPH insulins. Usually works for about 18 hours to 24 hours. So usually given once a day or twice a day. Premixed insulins, regular and NPH, your mixtards, etc. And rapid acting insulins is the Fiasp is available. And then rapid acting, the Lispro and Asparts are available. And the Glargine is a favorable drug, Lantus, or the Basigen, or the Basaglar. So they are the Glargines. And the degludec is the Tresiba. And the Glargine U300 is available, Tozio. And then the Ida gas, already I told you. And the short acting, the protominated is the Novomix or Humalong mix. So these are the different, all the injections are available in our place. So now concentrate on the onset of the action. The short-acting insulins, what you give the atropine or your insugen or etc. So onset of action is 0.5 to 1 hour. See, half an hour to 1 hour. Usually it takes 45 minutes to 1 hour. So that means when you should give the short-acting insulin, along with the lunch or before the lunch? Before the lunch. Okay. So what is the duration between the lunch and the insulin? Half an hour to maybe 45 minutes to 1 hour. Okay. That is not practicable in most of the cases. So most of the cases, times, no, they take the injection and they don't wait for about half an hour or 1 hour and they take the meals. Okay. Right. What is the peak action now? Your atropids and etc. Same thing. Next one, peak action. 2 to 4 hours. 2 to 4 hours. Okay. Suppose if the patient is taken the injection right now and immediately has taken the lunch. So what is his peak action? At what time? Suppose he takes the lunch at 1 p.m. He takes the injection also at 1 p.m. Okay. So this injection starts acting at 2 p.m. Okay. And the peak action is of 2 hours. That means 3 or 4 p.m. So he has taken the lunch at 1 p.m. So what will happen is postprandial blood sugars. Is it well covered or not covered? Not covered. Not covered. Okay. So by the time this is on the peak action, already postprandial part is over. Very high blood sugars. So by the time this is the peak action, hypoglycemia starts. Okay. So there will be the hyperglycemia because of the mismatch between the injection and the food, and there will be hypoglycemia because of the late onset action of your atropids. So that is very common in our clinical practice. Okay. So you give one atropid injection at 1 p.m. before the lunch, and these people will get the hypoglycemia at 5 p.m. or the 6 p.m. Because by the time it's on the peak action, there is no food inside. So that causes hypoglycemia. If you get the blood sugar at 2 p.m., the blood sugar is 250 or 300. Okay. So that is a very common mismatch between our insulin therapy and the food intakes. Okay. What is the total duration? 4 to 6 hours. Okay, 4 to 6 hours. Now you concentrate on the ultra rapid acting insulin analog. Ultra rapid acting. That's what we often use in our nursing homes. Okay. So what is the onset of the action? 6 minutes to 20 minutes. So 5 to 10 minutes maximum. So you need not wait for the food. So just give the injection and take the food. Immediately the action starts and immediately that will take care of the postprandial hyperglycemia. So again, peak action. What is the peak action? 1 to 3 hours. So that is usually our rice eaters. So mostly the postprandial period is only 1 to 2 hours. So that 1 to 3 hours hyperglycemia is taken by your ultra rapid acting like your Lispros or the Fiasp. So what is the total duration? 5. So for that matter, those people who can afford, and definitely this Fiasp or the Lispro is much more better than the your atropid or the insugens, etc. So that is the main difference between these two injections. Okay. And then you take the premixed insulins. That's a very common injection. Earlier, no, in India, the commonest insulin in the market is your mixtars. Now that the graph is coming down because of the usage of the other insulins. No, but still the mixtard is a very popular brand. See here. Okay, regular and NPH, 30/70 or 50/30. So what is the onset of the action? Half an hour, maybe half an hour to 1 hour. So what is the peak action? 2 to 10 hours. Whatever the total duration? 12. So that is the again there will be again the postprandial hyperglycemia and hypoglycemia with the mixtard population. See, for example, mixtard, if you give the mixtard, how many shots you give a day? 2 shots a day. So 1 shot before breakfast, another shot before dinner. So for example, you are giving the 20 units in the morning. So the patient takes the breakfast and at 12 o'clock or 1 o'clock he takes the lunch. But you are giving the mixtard at the morning only. So morning you are giving the 20 units. How much is the regular insulin? 30/70 means 30% regular, 70% long acting. So 20 units means 6 units. So 6 units is your regular insulin. 6 units is your regular insulin and about 14 units is your long acting insulin. So that 6 units may be sufficient for your breakfast hyperglycemia. When it comes to the lunch hyperglycemia, this 14 units of the long acting is not sufficient to control the lunch postprandial hyperglycemia. Am I clear? So that is the reason. So when the most of the fellows, when they are on the mixtard, post breakfast blood sugars may be the normal, but post lunch hyperglycemia is always there. So you check once. When the fellow is on the mixtards, so whatever is blood sugars in the post breakfast and the post lunch. Post breakfast, very good response because you are, that the mixtard is containing the rapid part in the first hours, first injection. But the long term, definitely they will have a postprandial hyperglycemia. So those things I will come to you at later time. So am I clear here? So these are the very, very important things. See the here, the glycogen and the determine why they are the popular. Because what is the peak action? Peak action. No peak. So no peak means no hypoglycemia. No peak means no hypoglycemia. So when the fellow is on the lantus or the glycogen or the tresiba, that is a degludec, the chances of having the hypoglycemia is very, very less. Unless this patient is also on sulfonylureas or the patient is also given some atropine or the regular insulin. Maybe hypoglycemia may be caused by those sulfonylureas or the regular insulin, but not by the basal insulin. See, what is onset? Onset is the length of the time before the insulin reaches the bloodstream and begins lowering the blood sugar. So you are giving the insulin in the subcutaneous part. So it has to reach to the bloodstreams to reduce your hyperglycemia. Where is the hyperglycemia? In the subcutaneous tissue or in the bloodstream? In the bloodstream. So it takes a lot of time. So that is the onset. Okay. Suppose you are giving the atropine or you are the mixtars, they are in the exomeric form. So that has to be converted to the monomeric form for the therapeutic action. So that takes a minimum period of the 30 minutes to the 1 hour for traveling from the subcutaneous tissue to the bloodstream and then conversion from the exomers to the monomers. So this is the onset. Okay. What is the peak time? Peak time is the time during which insulin is at the maximum strength in terms of the lowering the blood sugar. Okay. So that is the peak time. What is the duration? That is the duration. Long insulin continues to lower the blood glucose is the duration. So the onset, peak and the duration. So when you are choosing the insulin, you should concentrate on these 3 points. What about the onset? What about the peak action? What is the duration? To avoid the postprandial hyperglycemia and also to avoid the hypoglycemia before the next meal. So these 2 things are very, very important to choosing a correct insulin. So this is the beautiful slide showing the action profiles of the different insulins. See the first one, green. So that is the ultra rapid acting or ultra rapid Lispro and the Fiasp. See how beautiful they act. Immediately within the 5 minutes they start acting. So they act for about 1 to 2 hours and then slowly they come down. So that is the best way of treating our postprandial hyperglycemia. So with your lunch or with your breakfast or with your dinner, the best way to tackle this prandial part is by introducing your ultra rapid acting. And then next one is the rapid acting, and then the short acting and the regular one is the third one. So this is the third one. See, the third one takes a lot of time between this time. So that is the reason that may not tackle the postprandial hyperglycemia very effectively. And intermediate acting insulin is the NPH. This one that is also having the peak. And then these are peakless insulins is the these three are the peakless. They don't have the peak, so chances of having the hypoglycemia is very, very less. So they are the detemer or detemer 100 units or 300 units or the deglutec or the. So these are the commonly used insulin regimens in our practice. So the basal insulin. So usually you give it at the bedtime, maybe 10 units or maybe 0.1 to 2.2 units per kg body weight. For example, 70 kgs, you can give the 7 units to the 14 units, or blindly you can give the 10 units. So once in 2 days or once in 3 days, you check the fasting blood sugar, and accordingly you can increase the doses of these basal insulins. For example, today you have given the 10 units of the basal insulin. After 3 days, you are checking the fasting blood sugar. Fasting blood sugar is 150. So what to do? Increase the dose or reduce the dose? Increase the dose till you reach the target of your fasting blood sugar. What is your target of the fasting blood sugar? Maybe 100 or maybe 110 or 120. Okay. Suppose after the 3 days or the 4 days, the fasting blood sugar is 70. So what to do? Already the patient is on 20 units of the basal insulin. So that is, you are promoting hypoglycemia. So you have to reduce the dose of the basal insulin. That is very simple. So the basal insulin therapy is so simple that you just start with the 10 units or 0.1 to 0.2 units per kg body weight at the bedtime, and then adjust the dose of these basal insulin according to your fasting blood sugars. Once in 2 days or once in 3 days. When the fasting blood sugar is higher, increase the dose of the basal insulin from 10 units to the 12 units, or 12 units to the 13 units, or the 14 units accordingly, depending on the rise of the blood sugars. Otherwise, the blood sugars are 200 or 250. Immediate from 10 units, you can jump to 15 units also. So it's only your clinical experience will tell you how much hype must be there in the usage of these basal insulins. So that is a very, very important basal insulin. You have the two types of the basal insulin in your hand. One is NPH insulin, like your Insulatard for poor people, costing about 140 to 160 or 170 rupees. On the other hand, you can have the Lantus, that is your Glargine, or your Tresiba, that is your deglutec, costs about 600 rupees to 800 rupees. Okay, so that is about 400 units. This is about 300 units, because each 1 ml is 100 units. 3 ml vials will be available. So even if the Lantus is about 600 to 800, that contains 300 units. Just you are using 10 units or 15 units or 20 units. That means if you use the 10 units, so that vial will serve you for about 1 month. If you are using 20 units, maybe the 15 days. So 600 rupees or 700 rupees for 1 month or 15 days is worth spending, because no peak, no hypoglycemia. Suppose if you get the hypoglycemia at 1 a.m. or the 2 a.m., so definitely the patient has to be admitted in the ICU for observation. For 1 day observation, 15,000 to 20,000. So he will get this Lantus, about 100 Lantuses for his 10 years or 15 years period. So to avoid the admissions in the ICUs, because when the fellow is in the severe hypoglycemia, one has to be admitted in the ICU only, because that is the most dangerous one. I think a lot of the people, they die of the hypoglycemia rather than the hyperglycemia. Okay, so we should not keep it in the wards. So we have to keep it in the ICUs only. So we can avoid those admissions by prescribing the drugs which won't cause hypoglycemia. So this is all for the people who can afford. So those people in the general hospitals, so definitely we have to give something is always better than the nothing. So then the INH insulin has to be given, but take care of the early hours hypoglycemia, because it's having a peak. What you mean by the basal-bolus? Next one, basal-bolus means you are giving the basal insulin at the bedtime to reduce the fasting hyperglycemia, and bolus means a prandial insulin. So before food, so you are taking the breakfast, lunch and the dinner. You check the postprandial hyperglycemia of the breakfast, postprandial hyperglycemia of the lunch, postprandial hyperglycemia of the dinner. So for example, the fellows post-breakfast blood sugar is about 180. Post lunch 250, post dinner 200. So if you want to give one shot of the regular insulin, that is the bolus insulin, when you are giving before the lunch, yes, pre-lunch. So that is called bolus, basal bolus. So bolus means you are giving before the food, maybe one shot or the two shot. Prandial. Prandial means the fasting blood sugar is always normal with your metformin or with your other drugs. But always the postprandial blood sugar is high, maybe 300 post breakfast or maybe 350 post lunch. So there you have to give only prandial insulin. Prandial insulin means your Lispro or Aspart, etc. So that is called prandial. What is the premix insulins? So a combination of your regular insulin plus the mixed insulin. So that is the premix insulin. And here basal bolus is also there. Basal bolus is 4 shots a day. That is the basal bolus. Okay. Sorry, నేను ఇందాక చెప్పింది basal bolus is the 4 shots a day. 4 shots అంటే bolus before breakfast, before lunch, before dinner, and the basal insulin. Yeah. Maybe basal plus అంటే that's different. Basal plus means 1 shot before the lunch or the dinner. Okay. Basal plus. That is basal plus. See the basal only insulin regimen. See here. A basal only regimen involves adding a long-acting or intermediate-acting insulin to the OHS, existing OHS, or the non-insulin injectables, that is glucagon, GLP-1 receptor agonists, and is commonly recommended when the glycemic targets are difficult to achieve despite the intensification of the oral therapy. So this is the common practice here. We don't change the OHS. Whatever the OHS is taking it, continue the same OHS, but just add the basal insulin, because this is the time you have to add the insulin in those individuals, because always the HbA1c is beyond the 9 or the 10 or the 11. Is a known diabetic for the last 15 years or the 20 years. Still the HbA1c is beyond the 9 or the 10. So definitely continue the same OHS, just add the basal insulin to control the fasting hyperglycemia. And there is a one rule called as the FFF rule. FFF. Fix fasting first. So if you fix the fasting blood sugar first, so obviously the postprandial or the random blood sugars also may come down. So that is the most practical way of treating the chronic diabetics is introducing the basal therapy. So the basal regimen is straightforward, easy to initiate, and also easy to titrate according to your fasting blood sugars, and associated with the fewer hypoglycemic episodes, mostly no hypoglycemic episodes once you use the glycogen or the deglutec, and less weight gain also compared with the more complex insulin regimens requiring 2 or more insulin injections a day. So when you are using more 2 or 3 or 4 means you are one only basal, another one is the prandial. So the prandial obviously will cause hypoglycemia provided if the dose is very high. Suppose if the patient is not taking much food and you are giving the high units of the insulin, so obviously you are expecting the hypoglycemia. So this is the prandial only insulin regimen. In some cases, prandial insulin may be added with OHS to control the postprandial blood sugars. I told you. So already the patient is on the different OHS, but always the postprandial blood sugar is very high. So just add prandial insulin, say maybe Lispro or the Aspart, maybe 5 units or the 8 units or 10 units before the lunch or before the breakfast. You will get a tremendous improvement in the postprandial hyperglycemia. So that is the prandial only insulin regimens. A review of the studies comparing the prandial only insulin with OHS to a basal insulin regimen with OHA regimen showed greater improvements in the HbA1c with the prandial insulin regimens. So this is the premixed or the biphasic twice daily insulin regimens. The rationale for choosing the twice daily premixed insulin over a basal insulin regimen to intensify the therapy in OAD failure may be influenced by a higher baseline HbA1c and are the dominance of the postprandial hyperglycemia with most fasting glucose readings closer to the target. So here mostly the postprandial blood sugars are very, very high. The fasting blood sugars are not that high. So where you have to use the premixed insulins. Suppose if the fasting blood sugar is very high, whereas the postprandial blood sugars are near normal, what insulin you are supposed to use? Basal insulin. Basal insulin. Suppose only the postprandial blood sugar is 1 or 2 postprandial blood sugars are very high, so you have to use the prandial insulins. Suppose here always the postprandial blood sugars are higher. Post breakfast high, post lunch high, post dinner high. So the fasting is also a little bit high. So definitely you can use this type of the premixed insulins to tackle both the fasting as well as the postprandial hyperglycemia, and very easy to introduce and patient convenience. So 1 shot before the breakfast, 1 shot before the dinner. So mostly for the laborers or daily wages population. So this is very easy to introduce this insulin. But if you see the profiles, how they control the fasting blood sugar, how they control the post-treatment blood sugar, that is not, we are not that happy when compared to the basal-bolus therapy or the Basal-Plus. Here the Basal-bolus, that is the MDI, multiple day insulins. Intensive regimen is the best suited for the individuals with an active lifestyle and variable eating habits. Almost the Basal-bolus means most physiological way of treating the diabetes. Most physiological way of treating the diabetes. So it's very flexible one with an active lifestyle. It requires the frequent blood glucose monitoring. So at least once or twice a day, one has to get the blood sugars done to know whatever the fasting blood sugar, postprandial, post breakfast, etc. It requires multiple daily injections with two different types of the insulins. So one insulin is your prandial insulin. So we use the Lispro or the Aspart 3 shots a day and give one Glargine or one Deglutec at the bedtime. So that is your Basal-bolus therapy. Okay. So those people posted for the PTCA or CABG or renal transplantation or dialysis or sepsis are very high risk individuals, are amputated, or also with other comorbidities like uncontrolled hypertension, okay, or obesity. So those people with a strong family history of the vascular events, so blood sugars are very, very high. So such individuals, I think the Basal-bolus therapy is the most ideal because you are treating the most physiological way of treating the blood sugars. So taking the breakfast, the sugar is going up. You are giving one aspart to tackle that post-breakfast hyperglycemia. So he is taking the lunch, again hyperglycemia. You give one shot of the aspart or the Lispro to take care of that post-prandial, post-lunch hyperglycemia. Again at the dinner, he takes the dinner, give one shot. If he doesn't take the dinner, don't give the shot. At the bedtime, you give one regular, one basal insulin at 10 p.m. and that will take care of the basal hyperglycemia. So that is the best way of treating the people. See, I think the most of the people, they are very happy with this Basal-bolus therapy. So because nowadays the pens now with the 31 gauze, almost painless injections, very painless injections. So they feel very comfortable because neither hypoglycemia nor hyperglycemia. Most of the times their blood A1C is somewhere between 6.5 to 7 or 7.5. So once the fellow is on the Basal-bolus therapy, very rarely we see the HbA1c beyond 8 or the 9. So we advise this only for this active population, for educated population, and they live longer also because of the good glycemic control, avoiding the long-term complications. Okay. So those people with diabetic retinopathy. So again, the retinopathy means almost they will be also having nephropathy because retinopathy and nephropathy are very close friends. So if you don't control the blood sugars very effectively, the retinopathy population, so they may need the dialysis or the transplantation in the next 3 years or the 5 years or the 10 years. Suppose if you start on the Basal-bolus therapy to control the blood sugars very effectively, so definitely you can avoid that dialysis maybe for the next 1 year, 10 years or the 15 years or 20 years. So this is a very, very important. See, this is up to you as a clinician to judge which people are the ideal indicated to start with the Basal-bolus therapy. Very high risk individuals, very high risk individuals. And of course, type 1 diabetics, so we always go for the Basal-bolus therapy only. So insulin initiation and the titration algorithms. Premixed insulins are an important tool for the glycemic control in persons with the diabetes in India, especially. They are the fixed component formulations of the rapid or short-acting and intermediate or long-acting insulins for both fasting and the postprandial glycemic control because it contains both regular as well as the long-acting. But here they should be very compliant with the food intake. Okay, these formulations include the conventional premixed formulations. They can be dosed once or twice or thrice daily depending upon the patient requirement. Usually you give once or twice a day, not thrice a day mixed starts. Because if you give the thrice a day mixed starts, so definitely you can go for the prandial insulins. So why to choose a premixed insulin? Coverage of both the fasting and the postprandial. Effective HbA1c control, once you control the fasting and postprandial effectively, so obviously HbA1c also will control very effectively. Improved PPG control compared to the basal insulin alone. When you give the basal insulin alone, you are controlling the fasting hyperglycemia. You are giving the mixed starts means you are controlling both fasting and the PP. So that is the PPG control will be good here. A single delivery device, so one shot. Fewer injections when compared to the Basal-bolus. Less dosing errors. Convenient. and option to intensify the same insulin. So when to choose the premixed insulins in the Indian realities? Last one you read it. Limited resources and literacy. Simple and easy to explain, the insulin therapy is needed. Just one shot, 20 minutes before breakfast and maybe 10 or 15 minutes before the dinner. Or 40 minutes morning or 25 or 30 minutes in the night. So depending on the duration of the diabetes, depending on their hyperglycemia. Patients on high carbohydrate diet. So here you can give the 50/50 also. Now the mixtures 50/50 is also available. Those people who takes only high carbohydrate diet. So they eat 90% rice only 5 to 10% some onion or some etc. etc. Simple and convenient option needed for the intensification. So this is the very good slide, shows you patient factors to consider which insulin should be used for the initiation, whether the premixed insulins or your mixtars or the Novomix, or on the other side basal insulin only. So what is the postprandial increment? So see the postprandial increment. Suppose if the postprandial increment is more than the 54 milligrams, so go for the premixed insulins. If it is less than 18, so go for the basal insulins. So the more the postprandial hyperglycemia, use the premixed insulins. If the postprandial blood sugars is not that high, when the fasting blood sugars are very high, go for the basal insulins. And second question, is the patient likely to manage basal-bolus therapy when intensification is needed? So this patient may need the basal-bolus therapy in the near future. Then you start with the basal only, not with the premix. So start with the basal and then you can add the bolus dosages, like the prandial dosages later. If you start with the mixed-start insulin, you have to stop the mixed-start. Again, you have to start the basal-bolus therapy. So that will be a little cumbersome process. And the third question, is there a large carbohydrate intake at one or the two meals? When the fellow is taking the large carbohydrate like our rural Indian population, so definitely go for the mixed-start insulins only, because that contains both the fasting as well as the postprandial insulins. Is the patient's lifestyle is predictable? That is eating pattern, working hours. Then you go for the mixed starts. Rather than unpredictable, go for the basal insulins only, because basal insulins don't cause any hypoglycemia. So when to choose the premixed insulins, already I told you these things. So types of the premixed insulin formulations. Here 30% regular, 70% NPH. So 50/50 is also available. So the AD algorithm for the initiation of the adjustment to the insulins. See, once the first they start with the basal insulin. That is the guideline told by almost all the guidelines, whether it is the ADA guideline or our RSDDA guidelines, etc. So start with the basal insulin. It's very easy to start, and you add the basal analog or the bedtime NPH insulin, or assess the adequacy on the basal insulin alone. Slowly you can go up rate. So in summary, discovery of the insulin was one of the most important medical advances of the 20th century. Insulin is an important anabolic hormone. Insulin is essential in type 1 diabetes for survival and is widely used in the management of all types of the diabetes, type 2 diabetes, type 1.5 diabetes, or gestational diabetes, or secondary diabetes, etc. And both the inpatients and outpatient settings in type 2 diabetes for prolongation of the life. Development of analog insulins have allowed the more physiological insulin replacement. So a lot of advantages are there with the analog insulins. So weight gain is also less with the analogs. Hypoglycemia is also less with the analogs. Wide range of the insulin regimens available, which can be individualized to the patient needs. So nowadays, we have a lot of the advantages of the different insulin analogs, so that it's almost like a child's play if you are interested in the management of the diabetes with the insulin therapy. So thank you very much for your patient hearing.